My name is Fasika Woreta, and I'm the director of the Eye Trauma Center and the Ophthalmology Residency Program Director at the Wilmer Eye Institute. Today, I'll be discussing tips for resident telestaffing in the emergency department. Each year, there are 12 million ED visits or eye emergencies in the US. In many academic or medical centers, we know it's our residents who are taking the call. So thus communication with attendings or fellows with teleophthalmology is critical for the appropriate diagnostic triage. In community hospitals, attending ophthalmologists themselves may be taking the call, and communication with the ED staff via teleophthalmology is also critical. In other areas of medicine, telemedicine has been shown to augment resident education. There's limited data of the use of teleophthalmology in the ED setting and the effect on resident education. There was one study published from Tel Aviv University, and you can see here a video camera was connected to the slit lamp, and residents would communicate the findings to the supervising physician at home. And they did this on 49 patients and found 100% concordance with the diagnosis when the patient was examined the next day. There was also another study which was published as an ARVO abstract in 2014 from the University of Pittsburgh, which looked at the use of teleophthalmology in the ED. In this study, they used an iPhone 4 to either capture external photographs or fundus photography when they used an adapter for the panoptic to the iPhone 4. And in the majority of the cases, they did find the smartphone images were helpful. And in 1 out of 5 cases, the triage decision was changed by the use of this. So what is available today to use with your residents? So in terms of anterior segment photography, there are multiple adapters that allow for the attachment of a smartphone to the slit lamp. These range from hundreds of dollars, like you can see in this one. There's an eyepiece here that you would insert. You would take out the ocular for the slit lamp and insert this. So this is cost several $100s. There's more fancy ones that cost thousands of dollars. That's shown on the right side here. And iWiki has a summary of all the adapters that are available, and it does take practice. So I would recommend each resident have one so they can get used to taking the pictures. One thing that's important to remember is that residents may be tempted to directly text photos of patients to attendings or senior residents or fellows, and that is not HIPAA compliant. So it's important to, depending on what your electronic health record system is, to find HIPAA compliant ways for uploading of images. At our hospital, we use Epic, and so using Haiku, the residents can upload the images directly to the patient charts. And again, this is critical to remain HIPAA compliant. In terms of fundus photography, there are different options. So at our hospital, we invested in the TopCon, which is a non-mydriatic fundus photography camera. We also purchased the version with the OCT. So that's called the Maestro system. All in all, it cost about $40,000 with the OCT capability. And importantly, again, to remain HIPAA compliant, we were able to integrate the system with our EHR and imaging system. So again, it could be uploaded. And you can see this is a picture one of my residents took with the fundus showing papilledema, which was the most common indication for use of the camera. Our residents really love the OCT capability so that you can do the OCT through the macula to detect fluid. For example, if they're trying to distinguish a MAC on versus MAC off RD. They can also quantify in cases of optic nerve swelling, they can quantify the retinal nerve fiber thickness. So again, our residents enjoyed that extra added feature. So each July, we have a training session for how to use this, to use the TopCon machine. And we did encounter technical difficulties along the way. Sometimes they're unable to log on, find the patient in the work list. And so I do recommend having an IT person dedicated to troubleshooting. Since the residents are busy in the ED setting, if there are any delays in getting it to work, they would often abandon it. But again, the vast majority of our residents said they found it very helpful to have this in the ED. There's also portable non-mydriatic fundus cameras that you can purchase, which one is shown here, which is the Vogue. And these are good for inpatient bedside examinations, for example. And again, you can purchase it from various vendors. So I've discussed asynchronous methods of teleophthalmology in the ED. I think in the future, having a synchronous, using synchronous teleophthalmology where you can communicate with the resident, the patient, and get an anterior segment slit lamp as well as fundus photo at the same time would be ideal, because a lot of the history is critical in ophthalmology. So directly talking to the patient is useful. This was an example of something I used for one of our community hospitals, and I piloted where it did allow you to talk to the patient, but the limitation was that you could only get an external image, and I couldn't visualize the fundus. So although it was helpful in getting the history, I think there's more to be desired in terms of visualizing the fundus and the retina. So hopefully in the future, we'll be able to do that. So I'd like to thank everyone who invested in helping us implement teleophthalmology for staffing of our residents. And please do not hesitate to email me if you have any questions at fworeta1@jhmi.edu. Thank you very much.